My name is Charl Els and I'm a clinical professor in the Department of Psychiatry, and I'm appointed as a physician educator in the Division of Preventive Medicine in the Department of Medicine at the University of Alberta. This session focuses on the occupational impact of substance use disorders or addiction. Thank you to the Workers' Compensation Board of Alberta for making funding available for this project. There are no conflicts of interest to declare, and the opinions expressed in this session are those of the speaker and not necessarily those of any collaborator or project sponsor. This session focuses briefly on an overview of the features of substance use disorders, including causation, prevalence, diagnosis, treatment, and prognosis. It also addresses the occupational variables of capacity, risk, and tolerance. And at the end of this session, participants will be equipped to recognize substance use disorders as an occupationally relevant medical condition, describe the impact on those variables, and thirdly, broadly outline evidence-based interventions to achieve maximum medical improvement. What is a substance use disorder? The American Society of Addiction Medicine defines addiction, which is the equivalent of a moderate to severe substance use disorder as per DSM, as a primary chronic disease of brain reward, motivation, memory, and related brain circuitry. Dysfunction in these circuits lead to characteristic biological, psychological, social, and spiritual manifestations. And like other chronic diseases, addiction often involves cycles of relapse and remission. It's chronic. And without treatment or engagement in recovery activities, addiction is often progressive, which can result in disability or premature death. The diagnosis of a substance use disorder can be applied to all 10 classes of substances in the DSM-5, that being alcohol, cannabis, hallucinogens, inhalants, opioids, sedatives, hypnotics or anxiolytics, tobacco, cocaine, amphetamines, and others, but not for caffeine. So what causes addiction? The short answer is we don't know. It's likely multifactorial in nature, and genetics play a fundamental role in the cause of addiction. As is the case with most psychiatric conditions, a biopsychosocial model applies, and there are predisposing, precipitating, and modulating factors. For different kinds of substance use disorders, there are different genetic causation factors. What is the prevalence? Well, addiction is a common condition, and national samples suggest that just over 20% of Canadians, that being more than 6 million people, meet the criteria for a substance use disorder somewhere in their lifetime. Alcohol is the most commonly used substance for which people met the criteria for abuse or dependence, and that is at approximately 18%. More Canadians had symptoms of cannabis abuse or dependence in their lifetime compared to other drugs, and cannabis then is the most commonly used illicit substance. There's no single pathognomonic sign by which we can diagnose addiction. Drug testing certainly does not test or diagnose addiction. The diagnosis of addiction is made by taking a comprehensive history and performing a physical exam to rule out medical problems that may be mimicking, causing, or contributing to the symptoms of a substance use disorder, or to detect the chronic complications of the substance use or substance use disorder, of which there's a multitude. For the diagnosis itself, the physical examination is usually non-contributory, and special investigations are conducted only on merit of positive findings. An evaluation that includes psychological testing may assist in the diagnosis, as do the rating scales, for example, the DAST, the MAST, the CUDIT, the ASI, several others, confirms the presence of addiction, and it also assists with determining the intensity of the condition as well as for monitoring treatment response. Finally, using the criteria in the APA's DSM-5 allows for a diagnosis to be made with a reasonable degree of certainty. And as a reminder, this is a clinical diagnosis with no single diagnostic test to confirm. In the occupational mental health context, the diagnosis is reliant on careful observation, getting a detailed history, obtaining collateral information, and doing validity testing, for example, the SASE, where needed. Of note, there are significant changes that occurred from the DSM-4 TR to the DSM-5. The newest classification suggests that substance abuse and substance dependence, which were DSM-4 diagnoses, are now clustered together in a single diagnostic entity called substance use disorders. The occupational relevance is greatest for safety-sensitive work settings. Drugs of abuse exert their psychoactive or mind-altering effect by mimicking the actions of natural brain chemicals in complex neural networks that underlie human consciousness, perception, cognition, emotion, and behavior. Hence, it's plausible and foreseeable that those domains are impacted. The use of alcohol and other drugs, both licit and illicit, can cause significant functional impairment, which may result in serious occupational risk. Stages of use of alcohol and drugs associated with impairment include the following: intoxication, carryover effects, withdrawal, chronic toxicity and complications, and, for example, cannabis, where there's accumulation due to the high degree of fat solubility. For the range of substances of abuse, there's a well-established biological basis for performance deficits that translate into occupational risk. For example, capacity impairment related to alcohol and other drugs. Any of the substances or combination of substances that impair attention, alertness, coordination, reaction time, concentration, multitasking, memory, perception, insight, and judgment may theoretically pose a disproportionately increased occupational risk. Ongoing use of impairing substances in the context of an addiction is generally incompatible with and not recommended for working in safety-sensitive positions. It is important to realize that other mental conditions can co-occur with the substance use disorders, and the risk of impairment may hence be amplified. All of this said, despite increased risk, capacity may often be unaffected unless the individual comes to work under the influence of or actually consumes impairing substances at work or work within close proximity of using. Aside from screening for and treating psychiatric comorbidity, the effects of prolonged alcohol or substance use may impact the heart, the liver, or the central nervous system, resulting in damage to any of those systems. And this should also be taken into consideration when determining capacity and risk, and if there's a medical basis for limitations and restrictions. Occupational tolerance may be reduced due to addiction or its comorbidity, although it's not typically a concern with addiction. Tolerance, if diminished, tend to improve over time and with treatment. The treatment of the substance use disorders include, first of all, detoxification, followed by stabilization. And this could include both abstinence-based as well as harm reduction approaches. For safety-sensitive positions, typically moderation management is not recommended for drugs of abuse, not counting tobacco. It typically involves psychosocial and pharmacotherapeutic options, where available, and substance use, especially when comorbid with severe and persistent mental illness, may potentially increase the risk of violence. This warrants careful preventive measures as well as assertive interventions when risk is identified. Employers often have in place systems for individuals who are dealing with substance use disorders, and this may allow employees to proactively self-report and to be able to return to work under special contracts or conditions after treatment, often with a last chance agreement. Workplace monitoring and maintenance agreements are usually recommended for those re-entering safety-sensitive positions, and this would often include random drug and alcohol testing, typically conducted on urine and for substances identified as drugs of abuse. Remission of at least 3 months is usually required for a person to return to safety-sensitive work. Alternatively, accommodation in a non-safety sensitive position should be considered. Reaching maximum medical improvement varies across different classes of drugs, and it's usually achieved at about 6 months of treatment or less. Comorbid mental illness may prolong achieving MMI. The prognosis for substance-related conditions vary across different classes and is also contingent on comorbid mental health conditions. Although substance use disorders are considered chronic, treatable conditions, there are various factors that may impact the prognosis. The most important factor is that of treatment acceptance or motivation to change, which includes the individual's particular attitude towards care and treatment. Some individuals respond to treatment and may stay in remission from substance use disorders for many years, while some others may experience frequent relapses, similar to what we encounter with some other chronic diseases. Some individuals are never able to abstain from substances and do not experience periods of remission and may hence be permanently restricted from safety-sensitive duties. The category of substance use disorders or addiction is a common psychiatric condition that reflects a chronic, relapsing, bona fide disabling condition. Although it doesn't usually or typically impact occupational capacity in most cases, it certainly does increase occupational risk in safety-sensitive settings. Addiction is considered treatable, and what is required usually is 3 months of remission prior to return to safety-sensitive work. As a reminder, moderation management is usually not a feasible goal once addiction has been diagnosed, and abstinence from all drugs of abuse is recommended. For further information on the other sessions available, please visit the website of the division. We look forward to your feedback and comments, and please let us know if you have any suggestions for future topics. Thank you.